Hello and welcome to this learning module. Today we will review the information covered in your CPR training. This video is intended to supplement any readings or coursework assigned by your instructor. Upon successful completion of this learning module, students will be better able to, number one, differentiate CPR procedures for infants, children, and adults. Number two, perform foreign body airway obstruction procedures on an adult and pediatric patients. And number three, describe situations when CPR can be stopped or should not be initiated. Remember from CPR training that the adult compression to ventilation ratio is 30 compressions to 2 ventilations, and we want to provide those compressions at a rate of 100 to 120 compressions per minute. Remember to compress at a depth that is at least 2 inches or 5 centimeters deep, and we want our hands located on the lower half of the sternum. When performing CPR, we should limit interruptions in chest compressions to less than 10 seconds at any given time. When a supraglottic airway device such as a king tube, I-gel, or laryngeal mask airway is used, or a paramedic has inserted an endotracheal tube, rescuers should provide continuous compressions along with one breath every 6 seconds through the inserted airway device. When providing rescue breathing to a patient that has a pulse, the rescuer should provide one breath every 6 seconds using a bag mask device. When performing one rescuer CPR on a child, the compression to ventilation ratio remains at 30 compressions to 2 ventilations. When performing two rescuer CPR on a child, the compression to ventilation ratio changes to 15 compressions to 2 ventilations. Chest compressions on a child should be provided at a rate of 100 to 120 compressions per minute. The depth of chest compression should be approximately 2 inches or 5 centimeters, which is the equivalent of 1/3 the anterior-posterior depth of the child's torso. When performing child CPR, the rescuer can use one or two hands located on the lower half of the sternum, and CPR should not be interrupted for any longer than 10 seconds. When performing rescue breathing in a child with a pulse, the person managing the airway should provide one breath every 3 seconds. When performing one rescuer CPR on an infant, the compression to ventilation ratio is 30 compressions to 2 ventilations. Chest compressions may be performed using the tips of 2 fingers when performing one rescuer infant CPR. When two rescuers are present, however, the compression to ventilation ratio becomes 15 compressions to 2 ventilations, and the compressor should provide chest compressions using the 2 thumbs with hands encircling technique illustrated in the image seen here. Infant chest compression should be provided at a rate of 100 to 120 compressions per minute and at a depth of approximately 1.5 inches or 4 centimeters, which also correlates to approximately 1/3 the anterior-posterior depth of the infant's torso. As always, we want to limit interruptions to less than 10 seconds for CPR compressions. Rescue breathing on an infant that has a pulse should be provided at one breath every 3 seconds. When a patient goes into respiratory or cardiac arrest, time is extremely critical. Within 1 minute, the heart will start to become irritable and throw irregular heartbeats. After 4 minutes, brain damage becomes possible, and after 6 to 10 minutes, brain damage is probable. Once a patient reaches 10 minutes without oxygen, irreversible brain damage will occur. Of course, the patient's health prior to this incident plays a role in the type of damage they will sustain from prolonged periods of hypoxia. Patients with significant health problems may suffer more serious consequences. Most adult patients who experience a cardiac arrest event will present in a shockable rhythm, ventricular fibrillation, or ventricular tachycardia seen in the image here. The American Heart Association estimates that for every 1 minute defibrillation is delayed and effective CPR is not provided, the patient's chance of survival drops by up to 10%. So rapid initiation of CPR and deployment of an AED is key to providing our patients with the best chance of survival. To put things into perspective, think about the rule of threes, where the body can survive only 3 minutes without oxygen, but can go 3 days without water and 3 weeks without food. The devices seen here are mechanical CPR devices. The device on the left uses a piston to deliver chest compressions, while the device on the right uses a load distributing band that squeezes the chest and provides mechanical circulation. If available, these devices may be used during transport to the hospital. They will provide continuous compressions and free up personnel to do other things such as manage the airway. It's also a safer way to transport to the hospital without having an EMT standing in the back of a moving ambulance to perform chest compressions. Your agency may utilize active compression-decompression CPR devices like the blue one on the left of your screen. This device works by compressing the chest and then actively pulling it back up to its neutral position. The use of this device may increase the amount of blood that returns to the heart. The second device in this image is an impedance threshold device, or an ITD, that is placed between a BVM and an endotracheal tube or mask. The device can be used with any supraglottic airway or in conjunction with a BVM mask. The ITD is designed to limit the air entering the lungs during the recoil phase between chest compressions. This enables better circulation during chest compression. When these two devices are used together, some studies have shown an improvement in cardiac arrest survival rate. In the image on the right, we see CPR being performed on a CPR feedback device that is integrated into the manufacturer's AED pads. Devices like this are designed to provide real-time compression feedback that provides the rescuer with information about chest compression depth and rate. To review, cardiopulmonary resuscitation should be withheld in situations where death is apparent. These include rigor mortis, or stiffening of the jaw, neck, or extremities, dependent lividity, or blood pooling, body decomposition, or decapitation or other obvious non-survivable injury. CPR should also be withheld when an EMT is prevented with a valid DNR or MOST form. Once CPR is started, it should only stop in the following situations that you can remember using the STOP acronym. The patient S starts breathing and has a pulse. T, you've transferred care to somebody of equal or greater training. O, you are physically out of strength and unable to continue resuscitative efforts. And P, pronouncement of death by a physician, nurse, or paramedic. For an adult or child that has a foreign body airway obstruction, or FBAO, the rescuer should stand or kneel behind the patient and administer abdominal thrusts until the obstruction is relieved or the victim becomes unresponsive. Remember that foreign body airway obstruction techniques in an infant are very different from those provided to an adult or child. When an infant that is conscious and choking, the rescuer should alternate 5 back slaps and 5 chest compressions until the obstruction is removed or the infant goes unresponsive. When a rescuer is providing foreign body airway obstruction maneuvers on a conscious patient that becomes unresponsive, the rescuer should immediately begin providing chest compressions, as we discussed earlier for a patient in cardiac arrest. Prior to attempting to ventilate the patient, the rescuer should check the victim's airway to see if they can remove the obstruction. If the obstruction is not visible to the rescuer, then the rescuer should attempt to deliver rescue breaths and return to providing chest compressions. At no time should a rescuer ever perform a blind finger sweep on any victim of any age. While working a cardiac arrest in a patient's home or with family members present, it is important for us to remember that how we manage this event will be remembered by that family. If you have personnel available, assigning someone to stay with the family and keep them informed throughout the resuscitation process is a great idea. Remember that when we are speaking with the family, we need to use clear language, but also be compassionate and sensitive to what they're going through. Usually, the paramedic will notify the family if an in-home pronouncement is going to take place. When communicating with the family, you will notice that the paramedic will use the term died or dead. This is not to be cold or uncaring, but instead serves to let them know the outcome of the resuscitation attempt. Consider asking the family if there is anyone they would like called. For example, a member of the Catholic Church may want the priest to come to the home to perform the patient's last rites. The first few times you experience this as an EMT will likely be uncomfortable, but as you learn from your senior crew members and paramedics, this type of call will get easier with time. This brings us to the end of the presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, please consider going back to review any content that you might have struggled with. Thank you for watching this learning module.